Hi, Dr. Giri.
Hi.
How are you?
Good, good. How are you?
Good, good.
Okay, so let's okay. Can everybody see the screen now?
Yes.
Okay. So shall we just get started, or you want to wait?
Yeah, sure. No, let's get started.
Oh, okay. Okay. So I think we'll just continue randomly, the way we were doing yesterday. So if any one of you has any other suggestions, you can let me know. Uh,
No, yesterday was perfect. I think
Yeah. I
we
think
can
let's
proceed from
just
there.
start with something, and then
Yeah.
I think we will just
Yeah.
take it from there. So on my screen, I'm seeing an entity called lactating adenoma. Uh, so as we all know, I mean, this is something benign, right? I mean, uh, it's not there's nothing much really, about this. I mean, typically you would expect from the name itself for something like this to happen in a lactating or a pregnant woman. Uh, and during pregnancy, I mean, generally, nobody will do anything about it. They will just let it stay there because it's a benign thing. It's only after pregnancy that if it persists, then they may excise, because although it is benign, no person would like a lump, especially if it is a palpable thing in the breast, to stay there, so they may excise this. Uh, and generally it's simply a fibroadenoma, or a tubular adenoma that shows lactational type of changes. So it just gets the name because, as you can see secretions in each of these glands, and therefore the name lactating adenoma. And as you would expect, this will happen in pregnant women or lactating women. So I don't think that we should make much ado about this. I mean, this is a perfectly benign thing. Uh, what you need to distinguish it from is just lactational changes in breast. So those will be more diffuse. Uh, I don't think there is anything really special about this. It's just a fibroadenoma which shows lactational type of changes. As you can see, like even in the uninvolved kind of breast parenchyma in this particular case, you are seeing similar lactational type of changes. So it will happen within the milieu of lactating breast. Okay. Yeah, any questions about this?
Yeah, so it will develop while pregnancy, like it will not be present before pregnancy.
Yeah. I mean, typically that is how it will happen. Now, for some reason, in a non-lactating woman, if there is some hormonal kind of reason, you may get similar changes. And but again, this is a benign thing.
Right. And if we don't know that the person is pregnant, then we can just call it tubular adenoma.
You can call it tubular adenoma, or if you see so much of secretion, it's better to check from the clinician whether this woman is pregnant or lactating.
Right. Any difference in the management between the two?
There is no difference in management. As I said, in a pregnant woman, you don't want to do unnecessary surgery. So once they know that it's benign, they will not do anything about it. They will just wait till the pregnancy is over. And then if it persists, they may, decide to take it out.
Right. Got you. Thank you.
I mean, in many instances these days, as we all know, fibroadenomas are not even excised.
Mhm.
The reason for that is that anyway, these are detected by imaging. So they are small lesions and they can
Right.
be. A woman will not like to have a 5 centimeter mass, no matter how benign it is, they just want to
Right.
take it out.
Right.
But these days we detect fibroadenomas which are not palpable. They are detected during mammography or, screening ultrasound or something like that,
Mhm.
And then in those cases, when the stereotactic biopsy diagnosis is fibroadenoma, radiologists will not recommend excision. They will just ask them to come back after 6 months for a follow-up examination. If at that time the lesion is looking the same and of the same size, nothing will be done. They will be called again after 6 months. Now, during the interim, if the mass has increased, so now this means that it is a growing lesion. So if it is growing, then they will recommend excision. That is
Mhm.
how these things are managed these days.
So, for example, in fibroadenoma, we have like it can harbor DCIS, it can harbor invasive ductal carcinoma and others. So, does this like the lactational / tubular adenomas, they can harbor any neoplastic DCIS
Yeah,
invasive, or
yeah,
they can?
right. They can harbor anything. So that is why usually the way this works is nowadays because these are not palpable lesions, right? They are usually centimeter or around that, sub-centimeter. So when they do a core biopsy, that is a fair representation of what the lesion is like. Uh, Now, if you have a 5 centimeter lesion and you take only a small piece of it in a biopsy, you cannot be sure whether that is representative of the entire lesion. So these are two different scenarios.
Mhm.
So in these non-palpable lesions, usually the biopsy will be a good representation of the entire mass.
Mhm.
So there is less likelihood of any DCIS hiding, outside of
Right.
the biopsy tissue. Uh, but again, they will call them back after 6 months. So if something grows during this time, then obviously they will not, wait further. They will ask that the lesion be excised.
Right.
Okay.
Thank you.
Okay. So let's. Okay. So there is one DCIS here. Um, so since we were talking yesterday about DCIS, so this now is a different kind of DCIS. So first of all, unlike other DCIs, this is forming like a mass, right? So that is kind of unusual in DCIs. DCIs generally are detected on mammography because of calcifications. This kind of mass forming DCIS is unusual. So if we look at this, it's kind of solid looking DCIS, right? I mean, there are a number of these, units which are solid. Some of these are actually papillary. You can see some fronds here, which are compressed. So this is the so-called, solid papillary kind of lesion. See again how they are molded, each of these units, how they are molding against each other. So this is typical of solid papillary DCIs. Now,
Can
there are a
you
few
talk a
things.
little?
Yeah, so
Sorry.
there are a few things that we need to address when we deal with solid papillary DCIs. So one thing is that if you were to do immunostains, right? I mean, if you were to do myoepithelial markers, the chances are that you may not see any myoepithelial layer around each of these individual units. But that can be expected in solid papillary DCIS. Even in the absence of a myoepithelial layer, it is still DCIS, and we have to manage it as DCIS. Only if and only if you see conventional invasion, in other words, what we recognize as invasive carcinoma in association with this kind of change, then it becomes invasive ductal carcinoma in the background of solid papillary DCIS. Now, if that happens, then it has to be managed like invasive carcinoma. So the size of invasion will be whatever, that component of invasion is. And obviously, in those cases, in addition to lumpectomy, I'm talking about core biopsy right now. So in addition to lumpectomy, you would do a sentinel node biopsy. Now on core biopsy, if you see only solid papillary features, then they will manage it as DCIS. They will do only lumpectomy. So in lumpectomy, if you see any conventional invasive carcinoma, then they will do a sentinel node biopsy. And depending on the size of invasion, the further management will be based on that. So for example, if it is like, only micro invasive, like less than 1 millimeter, then they will consider that as micro invasive carcinoma. If it is more than that and up to 5 millimeters, then they will consider that as T1A. So most of the T1As, especially if they are ER/PR positive and HER2 negative, then there won't be any chemotherapy. They will do a sentinel node biopsy and hopefully the sentinel node is negative. If the sentinel node is positive, then there will be a question what to do, right? I mean, even then, generally, if it is micro invasion, like 2 millimeter or less of metastatic carcinoma, then they probably will not give any chemo. Nowadays, if anything is more than 5 millimeters of invasion, regardless of what what is the underlying change, even for solid papillary, if the invasive component is more than 5 millimeters and it is ER positive and HER2 negative, then they will send it for oncotype, especially if it is node negative. So there are a lot of permutations and combinations. These days they don't send, for example, anything for oncotype if the woman is greater than 70-year-old. But we are talking about only ER positive cases and HER2 negative. I mean, if something is HER2 positive, then they are not going to do oncotype for that. They will treat it, like a HER2 positive case. So those patients will get Herceptin and may also get other chemotherapy, regardless of the nodal status. Okay. I mean, this discussion will come up again and again when we talk about invasive cancers. So for now, I mean, solid papillary carcinomas are typically ER positive. So any invasion that happens, in this kind of scenario, it is going to be ER positive, luminal type of cancers. Now, if you don't see conventional invasion, then all this stuff will be treated as DCIS. So it will be solid papillary carcinoma without any conventional invasion. And for oncologists, this is, this would mean that they have to manage this as DCIS. That is the current WHO recommendation. I don't know if we will come across cases of encapsulated papillary carcinoma, but maybe we should discuss that entity also here. The encapsulated papillary carcinomas are also regarded as DCIS type of lesions. And according to the WHO recommendation, these tumors should also be managed like DCIS. Again, just like solid papillary DCIS, if you were to use myoepithelial markers in the assessment of encapsulated papillary carcinoma, the chances are that you will not see a myoepithelial layer. Now, why that happens, that is somewhat of a puzzle. The most likely explanation is that because of expansion, the myoepithelial layer attenuates so much that it may be non-detectable using immunohistochemistry. So it becomes so sparse, right? I mean, you can imagine, like, if you have a balloon, right? If it is not blown up, then and you have like a myoepithelium around it, and you do a cross section, you may see it, right? So it's like a duct with a myoepithelial layer. Now you keep expanding that duct, so the periphery of it will keep obviously, expanding, and whatever is outside of it will get attenuated because of pressure. And also it will get spaced apart. It will become discontinuous. So if you sufficiently expand it, then that myoepithelial layer, like in a given section that we are studying microscopically, it may be hard to find that myoepithelium. So although it may be present, those myoepithelial cells may be difficult to detect. And they may get so much compressed that they may become undetectable using immunohistochemistry. So in spite of the absence of myoepithelial layer, currently solid papillary carcinoma and encapsulated papillary carcinoma or encysted cystic papillary carcinoma, these are all considered and managed as DCIS. So you have to look for conventional stromal invasion to call something as invasive in this setting. Okay. I mean, a few years ago, like, when all this saga began, I would say like maybe 10 years ago, probably 15 years ago, there was a controversy. Some people, felt that because there is no myoepithelial layer, all of these tumors are invasive. So, I mean, what happened as a result of that is, let's say you have like a cystic papillary carcinoma, which is measuring more than 1 centimeter. So the size of that invasive carcinoma would be more than 1 centimeter, right? So it is already, now you're talking about T1C. So the oncologist would then have to treat something like that as T1C. They would send that for oncotype, and God forbid the oncotype score, if that came a little bit higher, then these patients would get chemotherapy. But they were treating DCIS lesion with chemotherapy, right? So all that stopped when WHO decided that no, we have to treat these as DCIS. So how did the WHO decide that? Obviously, there were follow-up studies, right? I mean, first of all, encysted or encapsulated papillary carcinoma or solid papillary carcinoma without any conventional stromal invasion, the lymph node positivity rate is extremely low. It is something like what you would expect in DCIS. So there is no reason to treat this as invasive, simply because you are unable to see a myoepithelial layer. So that put a stop to all that, So now, of course, there is a more or less universal agreement that unless you see stromal invasion, stromal conventional invasion, these lesions should be managed like DCIS. Okay. Any more questions?
Yeah, I have a question. So to differentiate between papillary DCIS, encapsulated papillary carcinoma, and solid papillary carcinoma, the immunostains, I believe, might not help. What are the things that help us, and does it matter?
It really doesn't matter, but it will be, once you see more of these cases, you will become familiar. So for example, an encapsulated papillary carcinoma, as the name itself indicates, like it's like a cystically expanded kind of lesion, right? Whereas our usual papillary DCIS, they will be smaller ducts, like, multiple small ducts, typically, which you will, will be papillary DCIS.
Like the case that we are seeing, like it's I mean, someone can call it solid papillary carcinoma. I was
Right.
thinking.
You can call this solid papillary carcinoma, but you have to say that there is no conventional stromal invasion identified. So that will tell an oncologist that they have to consider this as DCIS.
Right. Okay.
Okay. Now, I think that if you are working in a non-oncologic setting, then you may have to educate your oncologist that, these things are regarded as DCIS. I mean, where we work, this is not an issue, Once we write on report solid papillary carcinoma without any stromal invasion, then our oncologists know that this has to be treated like DCIS.
Right.
Okay.
Thank you.
I mean, this thing will come up again and again, and we will probably keep on discussing this, right? So I'm sure that people who are not on this call today, when they come up next time, they will have this question, Okay, let's go back. So there is this Paget's disease here, right? So let's talk a little bit about Paget's. I mean, we all have seen these cases, right? And it does not really add to the staging or anything, right? If you see it in the nipple, in a case that has DCIS or even invasive carcinoma, presence of Paget's disease does not change anything. Like it does not change the prognosis, it does not do anything. It's just tells us that these tumor cells have now creeped up through the lactiferous duct and have colonized the overlying epidermis. I mean, obviously, you don't want that nipple to stay there, right? You don't want to do a nipple sparing mastectomy when there is obvious Paget's disease there. Because, after all, there are malignant cells. So although they don't change the prognosis in the mastectomy case, I mean, these are malignant cells. So if you keep the nipple there and do a nipple sparing mastectomy in a patient who already has Paget's disease, then that's not a good idea because this will continue to grow and they may even cause invasive carcinoma underneath the skin. So anyway, right now our discussion is Paget's disease. So first of all, it does not add anything prognostically. This is something that we see morphologically, and also a clinician will note the scaly change or hemorrhage or something like that on the nipple. So anyway, he or she is not going to keep that nipple based on the clinical picture itself. So what else do we want to know about Paget's disease? So typically, the Paget cells, they are like hurt by immunohistochemistry, they are HER2 positive. And that's not a big deal really, and the reason why this probably happens is that most of the times, when you get Paget's disease, the underlying DCIS is typically high grade. And the high grade DCIS generally will be HER2 positive. And when we say HER2 positive, we are talking about immunohistochemistry. We are not saying that necessarily these mean that these cells are amplified by fish. Okay. So even otherwise, when you compare the HER2 immunohistochemistry expression rate of DCIS versus invasive carcinoma, for DCIS, it is much higher than for invasive. I mean, the invasive carcinoma HER2 positivity rate is what? 15 to 25%, or maybe maximum 30%. On the other hand, DCIS, by immunohistochemistry, the positivity rate is much higher. It can be 50% or even higher than that. But we are not interested in that because nobody treats DCIS based on HER2 positivity, right? I mean, at least not so far. And we certainly don't send for fish DCIS cases if we see HER2 2+ or something like that. It's simply that people have been using, in this Paget's kind of situation, HER2 stain, and they find HER2 staining. So a lot of people think that, oh, yeah, HER2 has to be positive if you want to call something Paget. No, it's nothing like that. I mean, it just happens. The reason why we see it more commonly is because the kind of DCIS that underlies Paget's kind of change is kind of higher grade DCIS. Very low grade DCIS is unlikely to cause Paget's disease because maybe that potential is lacking, for those type of DCIS cells to keep creeping along the lactiferous duct and then eventually colonize the nipple skin. Okay. I think whenever you have Paget's disease, it is important to carefully look at the dermis underneath, because once in a while you may have microinvasion in that setting. And that becomes important, microinvasion or even invasion. So we should not miss that. And it may be easy to miss because, as you can see, even in this case, there is so much inflammation here. So you have to meticulously examine the dermis so that you don't miss any microinvasion or even something like T1A. Because usually, whenever you have Paget's, there may not be any real invasive carcinoma in the breast. All you may have is DCIS. And you will therefore just say DCIS which Paget's involvement of the nipple. But you may miss actually the invasion that is there, and that could become problematic because I mean, if they haven't done a sentinel node, then they definitely need to do a sentinel node biopsy. I mean, oftentimes they will do a sentinel node anyway because they are doing a mastectomy. So they will have the sentinel nodes even if they are doing a mastectomy for DCIS. I mean, most surgeons, because they have access to axilla, they will do a sentinel node biopsy, regardless of whether they are doing mastectomy for DCIS or for invasive carcinoma. But of course, the presence of invasion and the identification of invasion is important. And therefore, we should not miss that when we are dealing with Paget's disease of the nipple. And if it is present, you have to try to measure it and categorize it, whether it is microinvasion or more than that. Okay.
Do we do any stains for these?
For Paget's, no, there is no stain. I mean, you will do the usual ER/PR and HER2, right? You don't need stains. I mean, the stain that you would need really is to rule out melanoma, right? So you would add, I mean, if that is a concern, obviously, if you're not sure that this is Paget's disease, then the other thing that you want to rule out is melanoma,
right,
or a melanocytic lesion. And you will therefore add the melanocytic markers,
right,
in addition to keratin.
Got it.
Okay.
Lovely. Thank you.
Okay, let's talk about microglandular adenosis. So microglandular adenosis is benign, right? We all know that. And this is a good example of microglandular adenosis. The glands themselves will be small, right? They tend to be round. And they have this eosinophilic secretions inside. So this is a classic picture of MGA, microglandular. And they grow in kind of a haphazard manner. Unlike our usual adenosis, which tend to be more kind of circumscribed and all, unless it's like sclerosing adenosis, in which case it will have sclerosing kind of picture. But these microglandular adenosis will grow in a haphazard fashion. And more interestingly, they can kind of grow in the fat. Sometimes they may grow exclusively in the fat. So see how this lobule looks different, right? So this is a normal lobule. So how different it looks from the MGA. These are almost like infiltrative, right? They create that infiltrative appearance. So this is a benign entity when it presents in this conventional form, typical form. If you don't recognize this as MGA, and you kind of think that, oh, this, because they can be infiltrative, right? They can infiltrate the fat. If you don't recognize this as MGA, then you will order stains like myoepithelial markers. So MGA notoriously, will not show a myoepithelial layer. So given the absence of myoepithelial layer, and you are actually thinking that, oh, could this be invasive? So now this supports your diagnosis, your assumption that, oh, this is an invasive cancer, right? So you will then make a diagnosis of invasive carcinoma. So that's something that you don't want to do. The other problem is once you kind of decide in the wrong way, actually, based on your myoepithelial markers, you decide that this is invasive carcinoma, then the next thing that you are going to do, because the oncologists want that information, the next thing that you are going to do is the markers, right? ER, PR, and HER2. Now, unfortunately, MGA is triple negative. So while a benign lobule will show at least some ER and PR, right? And so, but these guys, they will be triple negative. So now you are not only calling something that is benign as invasive carcinoma, but you are calling it as triple negative carcinoma. So you are making the situation worse. And based on the size and all, triple negative, oncologists generally are very aggressive when it comes to triple negative cancer. So even if it is T1A, they may give chemotherapy, especially in a young woman. So something that is benign, you are calling it invasive cancer. You are calling it as a triple negative cancer. And these unfortunate women, will now get chemotherapy for absolutely no reason. And this happens actually in real world. I mean, I know of a case where a patient got neoadjuvant chemotherapy for MGA. Because, nowadays, triple negative cancers, they become like eligible for clinical trials and things like that. I mean, look how extensive this is, right? So this, we don't have anything to measure, but something like this could be even 1 centimeter in size. So now you have a 1 centimeter triple negative invasive carcinoma. the patient will get neoadjuvant chemotherapy. And then after neoadjuvant chemotherapy, some women may elect to get a mastectomy. Although normally they, a lumpectomy may be enough, but some women, they are so sensitive to all these, cancer diagnosis that they may elect to get a mastectomy. And they will get a mastectomy for something that was kind of benign to begin with. And that fact will only be discovered after the mastectomy. Oh, this was only MGA, right? Because the mastectomy may happen in some specialized center. And that is where the people will pick up, oh, this was only MGA. And that's exactly what had happened to the case I am talking about. We saw a mastectomy in a patient who had MGA. So they will undergo sentinel node and all that stuff. So what is the answer to this? I mean, the answer is, first of all, you have to be aware, right? You have to think, could this be MGA? Because if you thought that this was MGA, then instead of doing the myoepithelial marker, the stain that you would order would be S100. Because these lesions are S100 positive. And that's really what you have to do. Confirm your morphologic suspicion of MGA. Now, if you are totally naive about this, then of course, I mean, you will only learn by making a mistake. And that is how sometimes we learn, by making mistakes. And the whole purpose of these sessions, like the one Akanksha is doing for all of us, is like, to increase our awareness. I'm sure most of you are aware of MGA, but I mean, even with all this awareness and all, as I said, that, we saw a case where the patient had a mastectomy for MGA. I mean, no doubt that particular MGA was not the usual MGA. It was like the atypical MGA. So atypical MGA will be something like DCIS, the cells will look malignant. So given that these glands themselves are infiltrative, when it is atypical MGA, unless you are sophisticated enough, those types of lesions are more challenging. And, in all likelihood, many people will call those as invasive carcinoma with tubular features or something like that. And those will be called as triple negative invasive carcinomas. So anything funny, unusual, beyond your comfort level, something that looks kind of new, you haven't seen it before you make a diagnosis, I think the number one rule is to share that case, show it around. So if you are working in a bigger group of 3, 4, 5 people, and the other people are more experienced than you, show it, before making a diagnosis. Maybe they will pick it up and they will tell you, hey, I don't think this is invasive carcinoma. They may themselves say, let us send it somewhere else, let us send it to a breast pathologist. Or so that is how you can kind of avoid, making mistakes. If you are in a solo practice, then the problems become bigger. So in those cases, if you see something which is new to you, I mean, that is how one should begin. If something looks different from what you easily recognize as a particular entity like invasive carcinoma, even if it looks slightly different, don't make a diagnosis, at least in the beginning, Because a lot of times we just learn by experience. There is no other way around this. So MGA is one thing which could potentially cause problem. See how it is infiltrating, right? Even the stroma, right? I mean, it appears to be infiltrating. Now imagine if these cells were malignant. like, DCIS kind of cells. So this will clearly become like a triple negative invasive carcinoma. And the patients will get some kind of nasty chemotherapy for triple negative cancer. And we have to also remember that many of our patients are very anxious, they have some mental kind of issues and all, and you never know how they are going to react. Okay. Okay, since we are talking randomly things, this is an interesting case. So gynecomastia, right? So, as we know, this is a problem that you will see in males, right? Once in a while you may see similar changes in a female, and in those cases, we may not use the term gynecomastia, but we will probably use gynecomastoid hypertrophy or gynecomastoid change. So this is a typical example of gynecomastia. They will form like a mass in a male. So that is how that person will become aware that there is something funny in his breast. So it's a benign lesion. There will be background fibrosis, almost like PASH-like change, and as in this case, this clefted kind of, PASHy kind of stromal change. That is a typical thing that happens in gynecomastia. And also the epithelial changes are quite remarkable. Once you see them, you will not forget them. So they will have these, ducts, multiple ducts, which are hyperplastic. And there will be a very peculiar stromal change, kind of myxoid kind of stromal alteration. And the epithelial changes are also quite characteristic. They tend to have this micropapillary kind of hyperplasia. This kind of micropapillary tufts. So this is very typical of gynecomastia. Now, sometimes it can become exaggerated, right? So you should not fall. It could be a pitfall, right? If it looks very florid and it could look a little atypical, then you might fall into this pitfall of making a diagnosis of ADH or DCIS. So if it looks very florid before you make a diagnosis of EDH or DCIS, it's best, if you are not doing a lot of breast pathology, to show the case to someone else. Now, ADH and DCIS can happen in the setting of gynecomastia. In fact, I diagnosed one case today where there was DCIS in a patient who had in the background gynecomastia-like changes. So that can happen. And many of these patients will get an excision, even just for gynecomastia, because even like women, men also don't like to keep like a mass in their breast. So they will undergo like, a lumpectomy kind of thing. But the radiologists, are very sophisticated because they will do mammography of something like this. And if there is a DCIS type of change, the chances are that that is associated with calcifications. So those calcifications will then be targeted. And that is how DCIS is generally recognized or picked up in patients who have gynecomastia. Okay. Gynecomastia itself is benign. Let's talk about nipple adenoma. So nipple adenoma has various names, right? I mean, nipple adenoma is one, florid papillomatosis of the nipple. So these are all synonyms. And these are benign lesions. And they are essentially, they are papillary kind of lesions. Here, for example, you can see that it has a papillary growth pattern. So they are basically papillomas of the terminal portion of the lactiferous ducts. Now, many times they may not grow like a typical papilloma. They may grow, that's why the nipple adenoma term, because like in this case, it is throwing all these individual glands, right? It is pretty much growing like an adenosis. So that's why the term nipple adenoma, because it may look more like an adenoma rather than a papilloma. But they are all variations of essentially some kind of a papillary growth that is happening in the lactiferous duct in the nipple. I think for people who are not doing a lot of breast pathology, in a very exuberant form and in an atypical presentation, especially if only a small part of this is taken out as a punch biopsy or something like that, one may overreact and call something like this as invasive carcinoma. Because if there is some sclerosis and all, these glands can look deformed and they may look kind of infiltrative, right? Pseudo-infiltrative. But for an inexperienced person, that may look like invasive carcinoma. And you may end up calling something like this as invasive carcinoma. I mean, in any event, the nipple would have to go, right? I mean, there is no other way here for a case like this, where the nipple, how is the surgeon going to remove this unless the nipple is removed, or at least portion of the nipple is removed? But you don't want to make a diagnosis of cancer. So one has to be familiar of this, entity, that something like this can happen in nipple. So unless something looks like a typical invasive carcinoma, it's not a good idea to call invasive cancer simply because something looks funny to you and sclerotic. The good thing is that in these situations, the myoepithelial markers will work. So at least if you do myoepithelial stains, then you will be rewarded and you will therefore safely make the diagnosis of something benign. And the other thing to remember is that regardless of how deformed the glands are, the cells themselves should not look malignant, right? Because this is a benign thing. They may be juicy, but they will not look malignant. So that's another pointer to something benign. And because, the nipple is going to come out, it's better to be circumspect, and try to show it to someone else or order stains before making a diagnosis of invasive carcinoma.
You can have something like this in a frozen section. How would you deal with that, on a frozen section? And
Yeah. So I think first of all, a surgeon should not do frozen sections. I mean, I think this is something that uh, is a big no-no to try to make a primary diagnosis. And the best thing is you should defer, right?
Mhm,
Don't make a diagnosis.
mhm. Yeah.
Any doubt, the best thing to do on frozen section is to defer the diagnosis.
Right. Yeah.
I mean, the only time really a surgeon might send or does send frozen section nowadays. I mean, there are really only two situations pretty much that are acceptable for frozen section diagnosis. One obviously is sentinel node, right? And the other is the nipple margin when they are doing a nipple sparing mastectomy. So that these are the only two that you should see frozen sections in breast pathology.
Mhm,
Now, I know, I mean, I'm talking only about how this is the ideal practice, right? But it is possible, certainly outside of the US. Like, I mean, in India, before I came here,
mhm,
the state of the art was, as you were suggesting, like, if there is a lump in the breast, they would not do like a core biopsy. They will take the lump and send it for frozen section. And if
mhm,
on frozen section you called something as cancer, then the next step was modified radical mastectomy. If you
mhm.
call something malignant, this is how it happened, right? Uh, but now, this is a big no-no. I mean, at least in the US, no surgeon should practice, this kind of thing. So if you get a nipple like piece of, tissue or a lump on frozen section, unless you are 100% sure that this is cancer, just defer it,
Mhm.
Don't be under pressure.
Right. I was wondering whether you can have this in the nipple margins, like that they send
Yeah,
more
nipple
closely.
margin, I mean, uh, obviously the surgeon would be sophisticated enough to recognize that there is some lesion there, right? So first of all, he
Mhm,
would not plan a nipple sparing mastectomy. He would first
mhm,
deal with that nipple lesion and
mhm,
decide what exactly that is.
mhm.
So, I mean, hopefully these situations will not happen. But
Right,
regardless of whatever happens, I would defer the diagnosis on
right,
anything that looks very florid and makes me uncomfortable.
right.
Okay, so here it says papilloma, something displaced, right? What was it? Let's go back. Displaced and trapped. Okay. Okay, so I think this is a great case, actually. So we will all recognize this as papilloma, right? There is some apocrine change as well. It's very florid kind of lesion, sclerosing. So if we go to the periphery of it, again, it's like a papilloma. So they had done obviously a needle biopsy, right? I mean, this is a needle tract. And this can be a huge pitfall. Like you can see here, there are single cells, single small clusters. So, I mean, your reaction would be, oh, there is invasive carcinoma, right? But these are all just entrapped cells in a needle tract. So stay away from trying to read anything in the needle tract, because this can be a huge pitfall. Never make a diagnosis in a needle tract. Okay. Doesn't matter what it is. Even if the surrounding lesion is DCIS, don't read anything inside the needle tract, because this is just artifact. There is no reason for invasive carcinoma to appear in needle tract. For
Sorry,
making the
Dr. Giri, can you show us the needle tracks on low power and how to recognize it? Thank you.
Okay, so this is the needle tract.
Oh, okay. Thank you.
So let's see at the edge of the needle tract. So at the edge of the needle tract, you will see that there is fat necrosis, right? So this is all because of the needle trauma. The fat necrosis that is. You may not see fat necrosis, you will only see scar in the middle of the needle tract. And they will be like linear, right? I mean, this is like this is where the needle, this papilloma or papillary lesion, somebody did a needle biopsy and they made a diagnosis of papilloma or whatever, right? So my point is, I mean, this I have seen, people making this mistake. They will read into this needle tract. Just ignore the needle tract. Don't try to see anything, Don't make any diagnosis in needle tract. Even totally benign ducts can get trapped. And even if you do myoepithelial stains here, they will all be negative. So don't do anything. Don't do any stain. Don't try to read any needle tract. Stay away from it. So this is a very florid kind of a papilloma, right? But see how different, it looks like very florid UDH. So if you have any question whether this is DCIS or something like that, I mean, in this kind of situation, you can do the CK5-6 stain. And that will help in making, in helping you make the correct diagnosis. Okay. Well, this is a different case from the one that we saw yesterday. So here, there are two things going on, right? So clearly there is some LCIS. I mean, all these discohesive cells, these are all because of LCIS. Now there may be some plasmacytoid look to it, maybe some nuclear pleomorphism and all, but essentially this is the LCIS, this part. And then there is a different type of this kind of, here we are seeing both actually. These papillary tufts have both LCIS in it and also DCIS. So this thing is like DCIS, micropapillary kind of DCIS. Even when we move away, now this becomes more recognizable as DCIS, right? So that can happen sometimes, you can have collision kind of tumors. So you can get both LCIS and DCIS. In these cases, usually you will also see more typical LCIS somewhere outside. See, for example, here, this is now more recognizable as LCIS, right? So what has happened here probably is that there was a DCIS that was growing and somehow the LCIS colonized it. See here. So there is LCIS that is growing around these ducts and it is colonizing. So this also happens in benign things, right? So you can get like a duct which has got usual ductal hyperplasia, but it gets colonized by LCIS, and then it becomes really problematic because it looks very bizarre. Like the one that we saw yesterday, there was a collagenous spherulosis which was colonized by LCIS, and that made it look like DCIS, cribriform DCIS. So for those of you who were not here yesterday, if we chance upon that same case, I'll bring that up and I'll show you. So this is typical DCIS, right? It also has necrosis in it. So micropapillary DCIS, which is colonized or which also is associated with LCIS. Any questions about that? We obviously will have discussion on LCIS itself because we need to address the unusual types of LCIS also. I'm just waiting to see any example.
I have a quick question. How
Yes.
do you mention these kind of combination lesion in your report? Do you say like LCIS along with the DCIS or something like that?
Yeah, you can, yeah. So, your main diagnosis will be DCIS because that's really, what is the more aggressive kind of, component. So you would say DCIS, describe it, and then you can say that, the DCIS is focally involved by LCIS or is associated with LCIS. And the LCIS also you should describe whether it is classical type or whether there is any pleomorphic. So for example, you can suggest that there are some pleomorphic features in this LCIS. But the real important thing is DCIS, right?
Sounds good. Thank you.
Yeah. Oh, time flies. Huh? It's already 5 o'clock. I didn't even realize.
Yeah, me neither.
Okay, so anyway, I think we should stop here. And,
Yeah.
this will go on, right? It's better to discuss everything properly rather than trying to rush through everything.
Agree with that, yes. Yeah.
Okay, great. Okay, so I'll see you tomorrow.
All right. Thank you very much, Dr. Giri. Thanks a lot.
Sure.
Thank you for your time.